Hello, I'm Warren Hall, the National Manager of Support Services for the American Liver Foundation. ALF, in collaboration with the Hepatitis B Foundation, held a two-day roundtable discussion on the hepatitis delta virus, otherwise known as HDV. This roundtable brought together people living with hepatitis delta, caregivers, physicians, and public health professionals. The goals of this gathering were first to identify unmet needs and priority issues for people living with the hepatitis delta virus. Secondly, it was to develop resources to better engage and support the larger community around hepatitis delta management. And finally, was to open better lines of communication between doctors, researchers, and those living with this virus. Overall, it was a very comprehensive and beneficial event for all of these reasons. One of the action items following the roundtable was to publish a white paper. A white paper is an authoritative report on a particular issue, in this case, hepatitis delta. Secondly, because this was an invitation-only event, we wanted to make some of the information available to the general public. And so for this reason, what follows are the insights and the reflections on the Hepatitis Delta Roundtable from two of the physicians who took part, Drs. Robert Gish and Dr. Richard Andrews. We hope you find these presentations insightful and informative. This program is part of the American Liver Foundation's Ask the Expert series. You can find more of this series on the ALF YouTube channel. And so now we present Drs. Gish and Andrews. I want to welcome Dr. Robert Gish to our discussion today. Dr. Gish is a clinical professor of medicine, and he's the medical director of the Hepatitis B Foundation in Doylestown, PA. He has many other affiliations that if you go to his website, you'll be able to see those. So thank you very much, Doctor, for being with us today to share your insights and some information for us on hepatitis delta, which we're starting to hear a bit more about these days. And we're always happy to have a teaching doctor on our programs because you're able to help the average person to understand complex medical issues. And so we really appreciate that, and we thank you for being with us today to be able to do that. But before we get started, you participated in the two-day Hepatitis Delta Roundtable. Can you give us just some of your overall reflections on that experience and why you feel that events such as that roundtable are important for medical discourse?
Thank you, Warren. Thanks for having me here today. And yes, indeed, that Delta roundtable, which was really patient-focused, patient-dominated, was fantastic. There were a few providers there, of course, was a chance to listen. We're giving lectures, we're talking, we're consulting, but learning how to listen, learning from listening, and really realize that the patients are our teachers. I think that was the biggest message. And I learned so many details about Delta and also about hepatitis B from that I've changed my practice since then. So Warren, thanks for having me involved. It was a great partnership between ALF and Hepatitis B Foundation and these other wonderful organizations that were present, including NVHR and NASTAD. There's so many people, so many advocates involved. The advocacy presence there was great too.
Yeah, it really was quite a gathering of folks that we all learned from each other. So now the content at hand, hepatitis delta, we're beginning to hear much more about this, but it's something that you've been involved with for quite a while. So we'll look forward now to some of your explanation about this virus, and just for people who might be viewing who themselves may be dealing with it or have a loved one, to help us to understand it a bit better.
Great. And this is a presentation that I developed with Tatiana Kushner, CLDF, Focus Med, for a meeting we had in Scottsdale. So I'm going to call this a pretty detailed presentation, but I'm going to take this presentation and present today because I think we're talking a lot to patients, support individuals, maybe some providers will be on this call today too. Warren, is that good to customize it towards patients today?
Yes, I think so, because those are the people that we really, the roundtable was an invitation kind of event. And so we really want to get this information out. So I think your approach is going to be perfect.
Great. So I've got some disclosures that are posted here. As I mentioned, this is a CME event that was accredited that you can log into. And if you're interested in CME, you can get that level of credit through the website. Focus Med did a fantastic job getting these slides organized. And Tatiana Kushner and I, Dr. Kushner is a associate professor of medicine at Mount Sinai in New York, an expert in the Delta space. So it was great partnering with her on this. And during this presentation, we talked about burden of disease, prevalence of disease, really how much Delta is there. How do you do testing? How does a provider get that into their clinical practice? And a message I'd like to have today to the patients is that if you have hepatitis B, make sure you ask for Delta testing through your provider if it's not already in your chart. That's a really, really important and simple message. We're going to talk about treatments, mechanism, efficacy, safety today also. And I'm going to move quickly through this because these slides are shareable. They'll be shareable through the ALF portal. This is being recorded. They're also available to the CLDF Focus Med website. I would highly encourage you to go there, download these slides, share those. And let's get to some really important messages. This is a complicated slide that I'm going to summarize by saying that Mario Rossetto in 1997 published the first paper on Delta hepatitis after doing some very elaborate research with, I'm going to call them rudimentary tools compared to what we have today in 2022, or even what we had 10 and 20 years ago. So this man is still alive. He's still a genius. And they did this incredible work, including electron microscopy, to help find this virus, to explain why some B patients with hepatitis B had rapidly progressive disease. It's a very special virus. It's an unusual virus. It's an incomplete virus that basically acts like a parasite on top of hepatitis B. Delta can't exist with B. Now, there are a lot of risk factors for Delta. And as you know, we're testing all adults for HIV, all adults for hepatitis C. And as of this year, we're going to be testing all adults for hepatitis B as in boy. Well, we're trying to get a message across to all the guidelines and CDC that anybody with B should be tested for Delta, because this risk factor history is not always accurate. People forget, they don't want to disclose. Taking a risk history can be stigmatizing to patients. And it's incredible. The CDC had made this major evolution and recognizing that taking a risk history fails and it's stigmatizing. So why not test all adults? And if you have B, check all patients who have B surface antigen for Delta. The prevalence rate varies all over the world. Some special places in South America, high prevalence, Pakistan, Mongolia, Central Asia, Eastern Europe, East Africa, and other countries in Africa where testing has taken place. We really think that there's 12 to 15 million people with Delta today, although some studies have said as high as 60 million. But there's problems with those studies. And 15 million is probably a good take-home message. I just skipped a slide on genotypes. It's very complicated. It's in the deck. If you want to know more about genotypes, you can take a look at the deck and also go to the reference. This gives you some different endemic country where there's a high Delta seroprevalence in B patients. I didn't mention Thailand, but Thailand's listed here. I think this may be an overestimate in Thailand because they went into risk groups. China varies from low in Eastern China to very high in Western China, because Western China looks more like Central Asia. India numbers here are probably high. If you go to the India border with Pakistan, you're going to find a lot of Delta. If you go to central, north, and south India, it's going to be extremely low. The Iran numbers, I think, are accurate. Italy numbers are accurate. Taiwan numbers are heading towards the low number on here because this was data that dates back multiple decades that came into this assessment when they had a big outbreak in Taiwan from sex workers. So we have insufficient testing. There's variable estimates in different countries depending on who gets tested. Testing accuracy in the US, I want to emphasize what we have here are antibody tests for Delta, which you do first, total, and then you go to PCR. And in this country, in the US, these tests are very accurate. In Europe, very accurate. But as you get into other low and middle income countries, highly variable without standardization. But you can trust today in the US, if you get a Delta antibody test that's positive, it's real. And if the PCR test is positive, it's real. There are occasional false negatives, negative tests, people still have Delta, but I'm going to give that an under 3% rule from what I know today. What about Northern California? I published this paper, it was 8%, the VA 3%, a study in the Midwest 3%, Baltimore high risk 11%, and Haynes, a study that's a CDC study, gave a very high number of 42%, but that was a special population with blood or patients' blood serum being referred for testing. So that's already a bias because there was always a belief. Take-home number for Delta prevalence in the US, 4% is a very safe number to think about today. A lot of risk factors. What I want to highlight on this slide is most patients have high liver enzymes. I want to remind you that ALT is not a liver function test, it's a liver enzyme. Low viral load in hepatitis B. Patient has surface antigen. Every patient gets a DNA PCR for hepatitis B, B as in boy. Delta parasitizes off B, suppresses B, but inflames the liver. High ALT, low hepatitis B viral load. Big message on this slide. Other factors, somebody with hepatitis C is more likely to have B, more likely to have Delta. High prevalence in B patients with cirrhosis. We mentioned high enzymes, low DNA. These are important factors to consider. This is a great map because this is the hot spots for Delta in the US. Illinois, New York, Florida, Texas, California. These are communities, these are regions, these are major metropolitan areas that welcome immigrants. It's an immigration country. We're all immigrants here at some time or other. These are hot spots for immigration and hot spots for Delta because Delta is going to be found predominantly in immigrant populations, but definitely in these risk populations we mentioned with high risk behavior. Let's talk about the virus for a moment. A lot of interesting things on here, but I'm just going to emphasize that Delta is this tiny, incomplete virus that needs B and needs the liver cells, host human liver cells, enzymes in our liver cells to help the virus replicate. So it's a double parasite, actually. It lives off B and it lives off our liver cells. It gets into the liver cell through a bile acid receptor. So we bring bile acid into our livers every day. We excrete bile acids to help digest food through fat digestion. But the way bile acids get back into the liver through a recycle system is the same way Delta gets into the liver by entering with hepatitis B as in boy. B hides the Delta underneath that surface antigen. Surface antigen attaches, releases Delta into the liver cell. Liver cell helps Delta replicate, package with the B, and go back out. A little bit more details on entry, but this amazing medicine that's approved in Europe, approved and sold in 4 countries in Europe, and hopefully will be in the US next year, called bulevirtide, binds to this receptor and blocks B Delta coming into the liver cell. But Delta can spread by going out and back in, or it can spread through cell division. So we're going to need to block the uptake. Eventually, we're going to need agents to clear the final virus by blocking and killing delta in the liver cell itself. So delta, this virus, can be acute or chronic. Acute meaning high enzymes, bilirubin, sick, and some people clear, not cure, and clear the infection. Or it can become chronic. And if it's chronic, 70% of patients will develop cirrhosis, need a transplant, develop cancer, or die. This is a rapidly progressive disease. D is for deadly. Be there for our D patients. Test all B patients. If they're delta positive, monitor them more closely. Stronger counseling about no alcohol. Stronger counseling about moderating fatty liver disease. This is a complicated slide, but basically says in most cases, delta dominates B. B replication is low, delta replication is moderate to high. There are some other variabilities, so every patient with B gets a DNA level. If they have delta, they get a delta RNA level, and then you figure out the balance. After acute infection, not shown on this slide, 30% of delta patients clear the delta. So you're going to find patients who are antibody positive, total antibody, PCR negative, meaning no virus in the blood. I personally, professionally, believe there's still delta virus hidden in the liver cell somewhere, and it can't come back out. There are people that are intermittently RNA positive on PCR. So once somebody has been tested and antibody positive, but the viral load is negative, we do recommend rechecking them every year for at least 3 or 4 years to see if the virus is oscillating, becoming positive. This goes into this issue about co-infection, getting infected at the same time, high rate of spontaneous clearance, or superinfection, meaning a person's surface antigen positive, then they get delta on top of the B after B is chronic. Most of these people develop chronic disease and cirrhosis and cancer, very high risk. This just talks about much higher risk of cumulative liver events, ascites, encephalopathy, decompensation, liver failure, liver cancer. Twice the rate of a hepatitis B patient progressing in half the time. D is for deadly. This just talks about things that might influence outcomes. Age relates to longer disease. Delta is worse than B alone. Region, part of the world, didn't matter. Liver cancer risk is higher, especially if they're delta RNA positive. It's a really important question. Do they have cirrhosis? Are they bordering on cirrhosis? When do you start surveillance for liver cancer? Screening is the first test. Surveillance is ongoing testing. I like to be very clear about that terminology. More virus, worse outcome. More virus, progression, liver decompensation, liver transplant, death, liver cancer. This is why we quantitate the virus through quantitative PCR. Red bars here, more virus. This just talks about people feeling badly when they are infected with Delta, feeling worse than hepatitis B alone. There's more data coming out on this in publications soon. So it's a little confusing who to test. AASLD says take a risk history, but that has failed. In the US, if someone has B, the chance of getting checked for Delta is less than 20%. Because risk history doesn't work, they failed, people don't take a risk history, they deny the risk, they forgot about the risk. EASL took a more simple approach. Check everybody. The right-hand column here is important because anti-Delta antibody is the first test. It's Delta total. Positive Delta total, go to quant RNA PCR. Very simple dot through. And eventually we want to get to reflex testing. Any patient who comes in, surface antigen positive, The lab, the commercial lab, boom, 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 just moves through antibody for Delta and then PCR RNA. A lot more on risk, but who remembers all of these regions and these maps? There's 200 countries. And there's something wrong on here. Vietnam does not have a high endemic presence of Delta. There's one publication that has not been confirmed that said Vietnam is high. Vietnam's going to be low, similar to Cambodia and Laos, and not as high as what we talked about earlier in this presentation in Thailand. Testing. This is a very complicated grid. I'm just going to say surface antigen positive, that's the top. You're then going to go to Delta antibody total, that's second from the bottom. It says IgG, but it really means total. That's positive. You go to PCR quant. Boom, boom, boom. Any of these settings, 3 tests sequentially done. Look at all these labs that have testing. The 2 most robust labs for testing are AREP and Quest. LabCorp, not yet listed here because they don't have Delta testing, but they will have testing this year. I don't know much about BioAgilytix, that's listed here, or ViraCore in terms of accessing them for Delta. But if you send it to LabCorp and they need to do a send out, they should send it to one of these reference labs. And the CDC is developing their own in-house tests also that they can use now more thoroughly as testing, screening, or testing confirmatory, although historically their tests have had very high performance. I'm not going to go through this slide. This is really a slide that talks about how good and how bad some of the tests are. The Chinese tests, not so good. Diasorin, mostly in Italy right now, excellent detection. This talks about how many people who are antibody positive have viremia. So it's about 2/3. The other 1/3, these tests aren't false positive. They're true positive. It's just the person has cleared the virus from their blood. They're still making antibody, of course. In fact, they're making antibody means there's probably some virus still hanging around. We would love to do reflex testing. That means surface antigen positive. It just goes to antibody and then goes to PCR. They did a study about this in London. And as you can see, when you talk about reflex testing, you go from basically no testing to significant testing. And then the number of people who are RNA positive was 32 compared to standard testing, which only found 2 people. So it's more than 10 times better or more than going through the standard test, come back, test, come back, test, come back. There is data that non-invasive fibrosis assessment works. This means what's called a fibroscan or elastography, FIB4 or APRI, which are blood tests that can be based off your blood chemistries, are accurate in determining the stage of Delta. So we have a large number of people infected. In the US, we think it's around 150,000. The number screened is maybe 20%. Less are diagnosed because no one talks to them about the antibody or people don't get a confirmatory test. And then managed is going to be in that same small group because if you're not tested, you can't be managed for your Delta. And treatment is going to be in the 1% range. People just don't want to take interferon. Right now, pegylated interferon is the only option to treat in the US. I mentioned bulevirtide is available in 4 countries in Europe, and it's conditionally approved by the EMEA. So that will continue to expand, and I'm expecting more sales of Delta treatment for bulevirtide in Europe. And then in the US, we're expecting late this year. This has to do with guidance. Basically, the big message on this slide is that if you don't clear virus, but the viral load drops down by a factor of 100, let's say it goes from 1 million to 10,000, patient outcome is better. Less cirrhosis, less cancer, less liver failure. Just resetting down 2 logs improves the patient's outcome. This is interferon trials. You look on the right column, 5 different studies. Cure rate, SVR, we're not going to call it a cure probably, 0 up to 40%. I take the middle number, 20%. I tell the patient your chance of getting treated and remotely curing this is low and chance maybe of 20%. Interferon has a lot of side effects. This is why even though people who are responding, people who are tested that are eligible, how many people want to get treatment, how many have a sustained response, it's super low, maybe 18%. But if people get treated, they have less frequent liver complications, and this is linked to viral suppression. Another important study that was done by our German and Turkish colleagues, but it was really a global effort, looked at a combination of PEG in red, that's interferon alpha 2A, with adefovir, an older drug for hepatitis B, with PEG interferon plus placebo. And you can see that across these studies that adefovir made no difference. So we don't use adefovir to treat Delta ever. It doesn't have any effect on Delta. It's good on B, not great, but good on B. So there's other drugs in development. We're expecting the second column prenylation inhibitors, lonafarnib, to be available next year. The far right column, bulevirtide, be available this year in the US. PEG interferon, I'm expecting probably 2024. And the rep compound, I'm not sure. The rep 2139 blocks packaging and release of the virus, B and Delta. This is just a map on where the different drugs work. We've already talked about this, but this is really nice for you to look at sometime. On the left are the side effects we have to consent people for PEG interferon. Bulevirtide, we've seen a few patients with liver enzyme changes, which might be viral clearance, increases bile acids, which does not have any clinical impact, in my opinion. Lonafarnib, the biggest issue is nausea, a lack of appetite, and weight loss. Nucleic acid polymers has been shown to both have marked AST and AL elevation in some patients over 1,000. And total bilirubin recently reported to be occurring from these naps. So the thing I want to talk about, bulevirtide, is a daily injection, no side effects, but if you're going to take it, you gotta be ready to inject yourself once a day with a super fine needle with few side effects. PEG interferon, if that's going to be used, I go through a 7-page consent with a patient. And we're hoping to get even more data with bulevirtide as that information rolls out. I think their lock date is done, data lock, and their submission will be in soon. And then in June, there'll be a review. So it's, I think this is interesting. Now it's going to be dosed at 2 milligrams sub-Q daily as a maintenance. That's indefinite. But in the real world, I believe bulevirtide is going to be used with interferon for 1 year. And I think the sustained viral reduction rate is going to be far above 50%. It's going to probably be in the 70% range, which would be fantastic. This is the European label, treatment of chronic Delta infection in RNA positive adult patients with compensated liver disease, administered 2 milligram once a day, subcutaneous as a monotherapy, or with a nucleoside or nucleotide analog. And I hope the FDA will approve it for the same. This is the interferon study with bulevirtide combination going out to 12 months. Look at this, viral control in combination was 94%. That's incredible. Now I'm expecting a number of people to relapse. That's why I'm saying 60-some%. This is lonafarnib, an oral medicine made by Eiger, and it showed a 2-fold or 100-fold increase in viral reduction of HDV RNA by inhibiting a host enzyme, but has probably a number of other effects as well. PEG lambda, a new form of pegylated interferon, appears to have less side effects. I'm going to say it does have less side effects. I was able to take care of a number of patients in Seattle who were on this compound. And also, I think it's very important to be thinking about this in terms of how you're going to be using this in combination. There's going to be an injection weekly, an injection daily. You really want to keep the side effects low to get them through a year of treatment. This just talks about lambda interferon reducing viral load by over 2 logs. 36% of these patients had undetectable virus. Lonafarnib and PEG interferon is moving forward. So you're really talking about combo. Bulevirtide will be improved as a single drug, but we'll be using it, I believe, in combination. Lonafarnib I think will be approved as a combo pill, but interferon won't be too far behind, and then we'll have that label. So we have on the left Lonafarnib, which is boosted with ritonavir. Ritonavir is also the boost in the COVID drug Paxlovid. So if you're thinking about this medicine, you have to think about drug-drug interactions. Ritonavir inhibits cytochrome B450 and can just make a mess of other medicines, especially if you're on immunosuppressants such as Prograf. There's this issue about Lonafarnib, ritonavir plus PEG lambda, which I think will be a great feature. So we want 70 to 80% of these patients cleared and cured. I'm not going to go into these studies in great detail, but this slide says Delta is complicated, and we as leaders in the community and through our guidelines need to really take this down to a much simpler level, because when you're this complicated, people don't get treated. They don't get tested. So we're going to make this simple in the future. Test everybody. Yes, take a risk history and help decide on retesting. LabCorp should be online soon. Mayo is online. BioReference hopefully will be online with this also. Mayo has a plan. That's basically what I'm saying. There's no use for Delta antigen testing, no role for Delta IgM testing. I'm asking directly the AASLD guidelines to update their guidelines and even, I think, roll out Delta into another subject. Let's see, I think we've covered everything on here. This is just a good summary of our presentation. Warren, I know we want to get to some Q&A. And these are all the people, not everybody, but these are people who have helped me, help my patients, help these drug developments, help epidemiology. There's lots going on in the Delta world, and there will be more this year, especially as we start curing people and add further to the safety profile of this drug, which I would say right now is safe. This is a way, if you scan this, you can get to the Focus Med CLDF website to potentially get CME credit. I'll just leave that up there, and Warren will go back to you.
Great. Yeah, thanks so much. And thanks for this to scan at the end here. This is a great way, instead of people having to quickly write down websites, etc. But so that is wonderful. So a number of things that you did say, and we did have a couple of questions. Clearing versus curing. So you made that distinction. So when you say clear, does that mean that it's not detectable, but there's no way to say that it's not there?
Yes. So we have to be very frank. Delta lives off of B. B is not curable. We use the term with B, functional cure, when they lose surface antigen and their DNA is negative. But if you use a more sensitive test or do a biopsy, you're going to still find virus in that liver. But by getting the viral level down that low, functional cure, that patient does extremely well long-term. Their liver cancer risk doesn't go to zero, but it's very low. Delta, same thing. We get rid of the virus, the RNA in the blood. The prognosis is much, much better. But we're not going to call it a cure. We call it, I think the best term is maintained virologic response. Maintain viral negativity. But I don't want to use the word cure. I know it's encouraging, it's optimistic, it's a positive message, but we also want to be scientifically and technically correct.
So the other thing that we do know, and this maybe falls in line with this, is the two ways that someone can have hepatitis D. So the first one is co-infection. So that means that when the person themselves contracts the hepatitis B, D is already present.
No, co-infection, they're getting B and D at the same time.
At the same time, right. Okay. And then superinfection, is that later? So
B is chronic.
Okay.
Delta comes on top.
Okay. Is one more dangerous than the other, or is having hepatitis D bad?
Different dangers. If you get B and Delta at the same time, co-infection, very high rate of acute liver injury, including jaundice.
Okay.
But an extremely high rate of viral clearance, over 90 to 95%. So you might go to a transplant, you might get really sick, or you get a lot better and you clear Delta, and you can even clear B in that wonderful setting. If you have super infection, you got B chronic, Delta comes on top, you can have a flare, you can get sick, but really the danger here is chronic disease, which is over 60% of the time.
So then, so screening versus surveillance. So screening, somebody gets the testing and they find out that they are hepatitis B as in boy positive. Let's say the D test is done immediately, no presence of that. But that person who is infected with B should remain in surveillance to make sure that D doesn't show up. Is that correct?
Yeah, there's two ways to think about this surveillance question. In that individual who you test and Delta antibodies negative, you're going to bring them back, build a relationship, and find out about risk behavior. If their enzymes ever change, their enzymes bump, their enzymes increase, you're immediately going to check Delta. Or if they come in and tell you, yeah, I had 5 sex partners, or I started using IV drugs again, or a patient I'm taking care of is from Kyrgyzstan, went back to Kyrgyzstan as an adult and got dental work and got acute Delta. And we think she got Delta and B at the same time, but she may have been B infected, not known it, and got Delta on top of it. So travel history, surgery, dental work outside the US. In Pakistan, I believe Delta is most commonly transmitted through dental procedures. So keep that in mind for surveillance in special patients. The other form of surveillance is somebody who's surface antigen positive, Delta antibody positive, but PCR originally is negative. That PCR could become positive in the future as the virus does some oscillations in replication. Oscillation means going up and down. Replication means making more virus. So it might be making a little for a while and then making more as the immune system and virus are going through a balancing act.
So in terms of, let's say, frequency then, and this I guess is a practical thing, how often should the positive hepatitis B person who does not have D, how often should they be screened ongoing to make sure that D is not present?
So surveying those people would be change in enzyme, change in risk behavior. I would check for Delta. So it's not going to be once a year or once every 5 years. It's going to be risk history and monitoring liver enzymes. I want to emphasize here, ALT, AST are not liver function tests. They are liver enzymes. And they would indicate a recent Delta exposure infection and reason to test. The patients who are antibody positive for Delta but PCR negative, I'm going to check them once a year for 3 years. If all Delta PCR tests are negative, I will stop and only recheck if their enzymes change.
So a little self-monitoring on part of the person to see if they're experiencing anything unusual or anything has happened that might put them at risk. Then they would follow up with the hepatitis Delta testing.
And if you're a patient with hepatitis B, you need to find a hepatology or gastrohep or infectious disease doctor that believes in Delta. There's a lot of hepatologists and gastroheps who haven't been checking for Delta until the person comes in with cirrhosis, dying, needs a transplant, or has cancer. We need believers. Now, we're spreading the word. This is a religious event. We're getting, hopefully, everybody on this train, on this boat. We're going to call it the Delta Force. That's going to bring Delta testing and knowledge to all people in our gastro, hep, ID, and primary care community. But we have a ways to go.
Right. And you know, Dr. Andrews, who was at the roundtable with us, is a primary care physician, and he is teaching other primary care physicians about this. And so, as you're saying, it's important for the medical community to get the word out to each other about this as well. You know, we see that in a number of areas in terms of liver challenge, whether it's fatty liver or whatever. We're trying to get, you know, physicians to be a little more involved with patients when those things happen, as opposed to just saying, well, let's see, you know, let's see what's happening. One final question somebody asks. So if they get to the point of cirrhosis and do get a transplant, will that cure are they then finished having to worry about B or D?
So it's a great question. And here is a bit of information about hepatitis B. Patient gets a transplant for hepatitis B. A tiny bit of the B will come back into that transplanted liver, but it is extremely well controlled with one of our three first line hepatitis B therapies, entecavir, TDF, or TAF. Those are two different tenofovir drugs. We also, right after transplant, give hepatitis B immune globulin. It binds and cleans up the virus. But those people getting a transplant for B are going to be on a nuke, an oral drug, the rest of their life. Delta, we treat the same way as B. We think the combination of HBIG, the new transplant, and the nuke suppressing B keeps Delta cleared in almost every patient. So these Delta patients, the message is they do very well with liver transplant, but with this careful approach.
Okay. Well, I think that from this point we say to be continued, because as you very well indicated that the studies are ongoing, the new medications are on the horizon being tested, and so it's something we're gonna have around for a while. But people need to understand that work is being done on it, and you know, hopefully as we've seen with hepatitis C, right, that eventually there is a cure. And so, of course, with any of these viruses, that is the hope. Not there yet, and maybe still a little far in the distance. But we know that the studies are going on. People are stepping up. Even there are clinical trials, right? That's something we didn't mention.
So there is an open clinical trial for Delta now through IGER. They're coming up with some new treatments, including lambda interferon. So you can go to the IGER website or the Hepatitis B Foundation liver or Delta Connect website. Delta Connect will talk about clinical trials, and there's incredible information and resources at Delta Connect with Hepatitis B Foundation, which I know is a great partner with ALF, and we're happy, Warren, that this partnership has been set up.
Yes, yeah, for sure. We're learning from each other and using our resources together, because the whole is greater than the parts when we all come together like this. So, well Doctor, thank you so much again for your expertise today. And I think down the road we'll have a follow-up discussion to this one as well. We wish you and so many other researchers in this area really all the best, and we hope that you're given the resources that you all need to be able to continue on with this. So, thank you so much for being with us today. I want to welcome Dr. Richard Andrews to our discussion now. Dr. Andrews participated in the roundtable, and today will give us some of his own thoughts and impressions of this very important event that took place. Dr. Andrews is a primary care physician who's based in Houston, Texas. He worked at the Hope Clinic, where he managed people with hepatitis B, which then led to his areas of interest, as well as studies in the hepatitis Delta world. Doctor, thanks for being with us to share your thoughts on the roundtable, and for this discussion about a virus that in many ways has really kind of gone under the radar for quite some time, and now it needs to be brought out into the light. So before we get into some of the specifics on hepatitis Delta, could you just reflect a little bit upon your experience as a member of that roundtable?
Sure. Well, I was delighted, first of all, that this very important condition, hepatitis D or hepatitis Delta, as it's sometimes called, that got a separate roundtable so that we could really focus on it. Hepatitis B, as we know, is itself something that many people, even over half of the people that have Hep B, don't even know they have it. And so you can imagine that hepatitis delta, which a small number of hepatitis B patients will have hepatitis delta. And so that's, as you put it, even less well recognized by both patients and physicians. And so it's terribly important. And it is considered by many potentially the most dangerous of the viral hepatitis viruses. And so it's terribly important that we do recognize it early so that patients are getting appropriate care.
Yeah, and I think one of the goals of the roundtable itself that we identified was trying to identify the unmet needs and the priority issues of people who are dealing with hepatitis delta. Now, in your work with people with hepatitis B, how would you assess in the early days of your doing this, how well, you kind of mentioned that people don't even know they have B, so let alone D. But how do you feel that has been coming along now in more recent times based on your own experience?
Well, I'm in the primary care world. My specialty is family medicine, and I also did a specialty in preventive medicine. And so where we can prevent something, it's better. Now there's two different kinds of prevention. One is not getting it in the first place, which is always best. But if somebody already has a condition, sometimes we can help people have what we call secondary prevention. You've already got the primary condition, the hepatitis B and the hepatitis delta, but are there things we can do that can still prevent a bad outcome, severe liver disease or liver cancer? So, but what I would do when I would see my hepatitis B patients is early on, as I was reading about hepatitis delta and which people were affected, in other words, some communities in different parts of the world are affected more than others. And so initially I was thinking, well, should I only screen certain patients for hepatitis delta, those that have Hep B, or should I be screening everybody? And I realized after a while that, because even though it's not that common, the people who do have it are severely affected. And so I switched to a policy of advocating essentially universal screening in the Hep B patients. So that was one thing I would recommend for any primary care physicians or anybody else, primary care practitioners, is that if they're taking care of somebody with Hep B, they should just do a one-time screening of everybody.
And so this is great that you were part of this as a primary care physician, because when people find out, and sometimes through accident, via an accidental finding, so to speak, that they are, let's say, at least they have the hepatitis B antibodies, they begin to panic and thinking, what kind of specialist do I need? What kind of a doctor do I go to see? And what you're saying is that, can people begin with their primary care? Is this something, and I know a little bit of your background, that you've taught primary care physicians about this. So what would a person do? Can they speak to their primary care, and what could they expect from that discussion?
Sure. Well, we're early in the days of successfully encouraging a lot of primary care people to care for Hep B. So it's possible that your primary care provider does in fact provide hepatitis B care. Now any primary care person who diagnoses or becomes aware of hepatitis delta, that person should not be managing the hepatitis delta. That requires a higher level of care. And so anybody with a diagnosis of hepatitis delta should be managed by a hepatologist. As far as whether the primary care provider would manage the Hep B, that depends on the comfort level of the primary care provider. And so for a person with uncomplicated disease, which is most people with hepatitis B have uncomplicated disease, and they can certainly be safely managed in the primary care setting.
And so what would somebody, so they just find out that they have hepatitis B. So the testing for that, so if somebody finds out they have the antibodies, there's still a little further testing they need, right?
Yes, absolutely. And I've had patients like this that I took care of here in Houston, where I would get an initial positive antibody result for Delta, hepatitis Delta. And I would tell the person, well, this is something we have to learn, find out more about. We have to do one more test, which is a confirmatory test that looks for the genetic material of the Delta virus, because there are things that can cause a false positive result on the antibody test. And so we always have to say, what I tell people is, we're going to do one test which says, no, you don't have it, or needs another test. I wouldn't tell them that the antibody test would say yes or no. I would say that it says either no, or it says needs another test. And so then I would say, oh, you got the needs another test result. Now we'll do this other test. And if that one's positive, then we have evidence of actual Delta infection. And then we'll manage it from that point on. In other words, by referral. At that point, we would refer to the hepatologist.
I think in our current times, people are becoming more familiar with the idea of virus because of COVID. So a lot of these things, false positive, false negatives, and so people are hearing this terminology in some ways for the first time, but it definitely applies because it's a virus, right? So a lot of this information really does apply to people dealing with hepatitis, because you're the folks that you saw. It was a wide range of the various viral strains, right, that you worked with.
Yes, although with the current modern therapies for, and I'm referring to hepatitis B here, B like boy, even though there are different strains, and we have to pay some attention to that in terms of things like liver cancer risk and things like that. The medications, fortunately, that we use for hepatitis B like boy, are equally effective with all the different strains. And so that part is not really, is no longer an issue.
Okay, great. And so, again, I'll go back to our roundtable discussion, unmet needs. What would you say at this current time, as we are trying to focus more on folks who are testing positive for hepatitis Delta, what would be some of the needs that you could identify currently that really do need to be worked on and assessed for some folks now?
Sure, I can think of, I would say, three things that kind of, two of them overlap. One, of course, is that the hepatologists, we had more than one hepatologist at the roundtable, but Dr. Gish, for example, spoke about the more recent prevalence studies that he and some other people have done. Prevalence, in this case, referring to how much of the condition is out there, how many people do have hepatitis Delta, because those numbers in the last few years have really been all over the map, depending on the study method and that sort of thing. And so we really have to get a clear idea. Dr. Gish estimated that in the US, for example, that the overall amount of hepatitis Delta would constitute about 4 or 5% of the hepatitis B population that would end up having hepatitis Delta. And of course, most of them don't know about it. So we have to, now there were some studies that showed somewhat larger prevalence, but he feels that that was, because of the way the studies were done and where the studies were done. He felt that 4 or 5%, but that's still a pretty large percentage when you talk about, especially for a condition that is largely unknown to many people, including even many doctors. And so 4 or 5% of a very serious condition is considerable. And again, fortunately, there are we don't want to scare people, but we want people to be aware of the need to find out if they have it and the need to then get it managed appropriately. And there are some new treatments becoming available and that sort of thing. So, and then the other thing is, it was so interesting at the roundtable, and I appreciated having 3 people there, two patients and 1 family member who directly affected by hepatitis delta. And so it's not theoretical for them. And what they made very clear, which was very helpful to all of us, I think, is the need for information, useful clinical information where they can have their questions answered and stuff like that. So we would certainly want to make sure that the patients, sometimes patients feel kind of bewildered by the complexity of the information, and if the information is given to them, is it given to them in a way that they can understand, and then they have the opportunity to do follow-up questions, for example. So I would say that's terribly important.
And so, which makes complete logical sense, is that before you can meet the needs of something, how great is the need? And so that's where the identification of how many people are dealing with this. And an important thing I think that you said for people who may be infected or find out they're infected is, don't panic if their own doctor is not aware of this yet, because of the fact that, like anything else, we do want our doctors to know everything. And we want every test to be confirmative, and we know that in the medical world that's just not the case. So what you're saying is, if you're a primary care who is maybe your first person you go to speak about it, maybe for insurance purposes or because a person you're familiar with. So don't panic if the physician does not know something about this. Who then would a person go to then in terms of the specialty field?
It would be primarily liver specialists, also called hepatologists. But I would also say that if you don't have ready access to a hepatologist, a liver specialist, any infectious disease specialist would at least have a clue and would have studied it and that sort of thing, and in some cases may manage it. But because hepatitis D, as we said before, is capable of aggravating the liver disease that a person may have from the hepatitis B, at some point they're going to have a hepatologist engaged anyway. So I would say even an infectious disease doctor who has studied hepatitis D is also going to be engaging a liver specialist. And so I would say, yeah, a hepatologist or liver specialist would be key.
Because they'll want to monitor the health of their liver at pretty much every point now moving forward, to be sure that liver damage is not forming, or if it is, the extent to which it's happening, right? So that's why they would want to do that.
Absolutely. And then the other thing that's interesting is with hepatitis B, which of course you have to have B first before you're even eligible to get hepatitis D. Hepatitis D cannot infect you by itself. Their hepatitis B has to be in a person's body to begin with. And there are some hepatitis B patients, those that do not have Delta, and they are sometimes at low risk of getting cirrhosis and liver cancer. And so sometimes, especially with young patients, we may not right away put them on a medicine for the Hep B. But if we find out that a patient has Hep D or Delta, then they absolutely have to go on the medicine for Hep B. That's the absolute first thing. That would be every single patient with Hep B and Hep Delta should. Then the question of should they start their Hep B medicine, that question is in the past, and now we would absolutely, because it helps protect the liver, even though the Hep B medicines don't directly treat Hep Delta, but they nevertheless, you wouldn't want two uncontrolled things bothering the liver. It's bad enough to have one. And so at least the medicines are excellent for controlling Hep B. That would be an absolute baseline. And even a primary care person could start that while they're waiting to get the patient into the hepatologist. Maybe it'll take a while to get into the hepatologist, but you could start that because no hepatologist would disagree with that move.
And finally, you mentioned about teaching doctors, especially primary care physicians, about this. I think the idea of doctors learning or continuing their education is of interest to folks. So how do you teach the primary care physicians about this? What are some of the key elements of this that you feel that is important for a primary care physician to know in case they do encounter this in their practice?
Yes, well, a couple of resources. One is if you have, as a primary care person, a primary care provider, if you have access to an ECHO program, ECHO, that's what they call the teleconsultation. Some people call it telemedicine, but it's more properly called teleconsultation. And the patient is not present at this session. It's a session that's at a particular date at a particular time, like it might be the third Tuesday of each month at 12 o'clock or something, typically an hour long. And it doesn't have to be in your region, but that would be, we sort of recommend that to start out with. If you can find, in other words, a liver echo or a hepatitis echo, then there will always be a hepatologist involved in these echo sessions, and you can learn a great deal, and you can get free CME, and then you could ask any question you want about hepatitis delta or hepatitis B for that matter. And so that would be one of the resources I would recommend. And of course, the American Liver Foundation would be another great resource.
Well, thank you for that. And the Hepatitis B Foundation, who we collaborated with on this project. So, Doctor, any closing thoughts? Any final thoughts about the experience? Or, we do talk about action items. So, in your own mind, coming out of this experience for you personally, what are you thinking about action items for yourself as we do move ahead now?
Yeah, well, one of the things I'm really fascinated by is because, patients do things on their own behalf, providers, physicians and other care providers do things on their, on behalf of the patient, but communities can also have a response. And I think that's something that's an underutilized resource. Let's say, for example, you have Mongolians, for example, those Mongolians that happen to have hepatitis B, they have a higher number of people affected by hepatitis delta. And then there are some other parts of the world. For example, there are some areas in sub-Saharan Africa, in Central and West Africa, for example, that also have, again, this is only among the hepatitis B affected patients that may have a somewhat higher prevalence. I mentioned 4 or 5% earlier, but that's the general population in the US that has hepatitis B. In certain communities, certain populations, among refugees or immigrants, for example, it's going to be higher. And we need to make sure that we, that members of those communities, advocates for those communities, people who work with people from other countries are aware that the community itself can have a response and can become advocates and can get the word out and do outreach. So I would say that would be something that we should really try to develop if we can.
Great. Well, thank you so much. And on behalf of all of us, I want to thank you for having participated in that roundtable discussion and for sharing your thoughts with us today.
Thank you, Warren. And I was really happy to be involved in the roundtable, and thanks for doing this.
Of course. Thank you, Doctor.